Hi, welcome to this educational session on how genetic information can generate new uncertainties for prospective parents. The aim of an educational session is to provide a state-of-the-art yet basic educational talk for an audience that are not experts in the field. So that is what I will try to do for the next 25 minutes. Before we get started, I want to thank the organizers and in particular Stina Lou for this opportunity to present and discuss a topic that's very close to my heart. In this presentation, I will take you on an emotional roller coaster ride with the fictional characters of Daniel and Simone. I will use their case as an opportunity to present and discuss how patient perspectives can inform clinical practice. I'm very sorry that we can't do this face to face, but I do hope that some of you will join the online discussion on Monday evening and share your comments and questions. My name is Stina Lou, and I am an anthropologist with a PhD in medicine, and I work as a senior social scientist at the Center for Fetal Diagnostics at Aarhus University Hospital in Denmark. For the past decade, I've conducted qualitative research within the fields of prenatal screening, fetal medicine, and prenatal genetics. I've done some qualitative research on prospective parents who receive an uncertain genetic result during pregnancy. In that study, I observed and recorded consultations. I interviewed the parents after birth, and then again 2 years after they had received the result. In addition, I've been fortunate enough to be part of an international research group where we have been curious about uncertainty in genetics and have explored that in different ways. So this is my platform from where I'm speaking about uncertainty for prospective parents. And if you're interested in a full reference list for this presentation, then send me an email and I will be happy to forward it to you. Okay, so let's say hi to Daniel and Simone. They are a happily married couple in their early 30s. She's a teacher, he works in accounting, and they're pregnant with their first child. Just like most pregnant women in Denmark, Simone had a first trimester ultrasound scan and a risk assessment for chromosomal disorders. Unfortunately, that risk assessment came up with a high-risk result for Down syndrome, which was a bit of a shock, but the couple quickly decided to have an invasive diagnostic test that could hopefully rule out Down syndrome or other severe diseases and syndromes. After waiting a few grueling days for the result, they finally get the call from their obstetrician. He says that while the test did not show Down syndrome, it did identify a genetic variation on chromosome 22. And as he's not a geneticist, he cannot really explain to them what this variation means, but Daniel and Simone should definitely come in for genetic counseling on Monday morning. Imagine getting such a message. Just complete and utter shock. What does it mean? Daniel starts Googling, but he doesn't really know what to Google. He's a typical maximizer who feels a strong urge to continue to seek information and answers in the face of uncertainty. Simone is curled up on the sofa, imagining all the horrible things that might be wrong with her baby and if she will have to terminate the pregnancy. Now, I think you should also imagine being the clinical geneticist consultant that has to counsel Daniel and Simone on Monday morning. Not an easy task. I will return to that shortly. In Denmark, all prenatal invasive samples are analyzed using chromosomal microarray. As many of you will know, a recurring concern with CMA is the identification of copy number variants, where the significance and clinical implication for the unborn child can be difficult or impossible to predict. It could be increased risk for psychiatric disorders, for malformations, for obesity, for delayed development. Some children may be very affected, while the majority will not be. In this presentation, I'm speaking of both known CNVs with reduced penetrance, we call them susceptibility loci, and variants of unknown significance, as both of them may generate significant uncertainty. Will my child be affected? How might it impact our family? Prospective parents must figure out what this information means to them and ultimately whether they want to continue pregnancy or not. I also want to stress that this group represents the small minority who, in my perspective, pay the price for the increased diagnostic yield of chromosomal microarray that is to the benefit of the majority. So in search for severe illness and syndromes, we sometimes come across deletions and duplications that are tricky to predict, like the one that Daniel and Simone are about to be presented with. However, in these discussions about uncertainty, I think it's important to remember that uncertainty is not an adverse outcome, but a constant in human experience. We navigate in uncertainty all the time. We are never merely victims of fate or uncertain genetic results, and our attempts to control, manage, or reconcile with uncertainty are integral to human life. And these attempts to control an uncertain future is exactly what drives us towards knowledge. In anthropology, we speak of the imperative of knowing. Several studies have shown that prospective parents often want maximal information about the health of their baby. As one informant formulated it, our philosophy was, you're taking a sample, so test the hell out of that sample. The presence of information-generating technology implies a social and moral obligation or experienced desire to use it. Many Western societies are shaped by a dominant social norm to face the facts, based on the conviction that with knowledge we can control, prevent, intervene, and act to create certainty and a desired future. Therefore, couples like Daniel and Simone risk being blindsided by uncertain results that instead of certainty and control generate new and unexpected uncertainties. So let's see how they're doing. Following a horrible weekend comes Monday morning, and Daniel and Simone arrives at the Department of Clinical Genetics for the consultation. Daniel carries a folder with different pages he's printed from the internet. Simone looks tired and tense. Now, how do you think the clinical geneticist consultant should approach this? She has identified a small 22q11 duplication. It's a susceptibility loci that could result in neurodevelopmental disorders and malformations to the heart, but it could also not affect the child. Also, she's found out that the variation is inherited from Daniel. How do you break such news? In this case, the consultant starts the counseling by saying, we have not found what I would call serious disease or genetic variation in your pregnancy. Why is that sentence important? Because you can literally see the weight being lifted off of Simone's shoulders. Now she's ready to hear about the result. So what is good counseling for parents in this situation? They are nervous, blindsided by results, complete novices in genetics, and worried about the health of their baby. The answer is, of course, that there is no simple recipe, but I have found much inspiration in this paper by Werner Lin and colleagues. They argue that genetic counseling can become overly focused on the technical and statistical aspects of genetics and suggest that in the face of increasing uncertainty, genetic counseling must return to its roots in providing a balance between the science of genomics and the art of counseling. Only that way can we help patients and families create pathways through uncertainty. In my opinion, this paper has many useful considerations and recommendations, but I want to focus on a few points that are also played out in the counseling of Daniel and Simone, namely that information is necessary, but we must beware of information overload and use accessible terminology, and that information is necessary but insufficient for decision making, and that concerns, emotions, and values should also be addressed. Because honestly, Daniel and Simone know very little about genes. Is it something with DNA? How are genes and chromosomes related? Are they the same thing? So the geneticist takes a moment to explain, using the metaphor of a library. She says, I usually think of the chromosomes as our personal library with 23 pairs of bookcases. In each bookcase, you need 2 copies of each book, one from the mother and one from the father. In your case, there is an extra copy of some books in bookcase number 22, and I want to talk to you about what that might mean. Later in the conversation, she returns to the library metaphor to remind Daniel and Simone that in all the other bookcases, there is the correct number of books. And by knowing that, we have ruled out many severe diseases and syndromes. So by using accessible terminology of the library, she points the couple's attention to what we do know. Many severe diseases and syndromes have been ruled out. However, Daniel is still struggling with the result. He wants to know what the geneticist means by delayed learning and how high the risk is in percentages. He's done quite a bit of research on the internet over the weekend, and he starts going through the printed papers, asking about the statistical risk for autism spectrum disorders and for malformations to the kidney. Daniel has gone into some sort of analysis paralysis, as if he can somehow calculate his way out of this situation, and that the numbers can tell him what to do, whether to continue or terminate pregnancy. The geneticist cuts him off. There's a limit to what the data can tell you. At some point, it stops being a value because we're all looking at probabilities here. So you really have to get back to your guts and your sense of this whole situation. There are some uncertainties. Can we live with that? This is not the type of uncertainty where you can calculate your way to the right decision. As argued by Bernalin and colleagues, emotion and gut feelings also have a say. After a short silence, Simone dries her eyes and turns towards Daniel. Well, I'm looking at you thinking that I wouldn't mind a little copy of you. The importance of gut feelings and other ways of knowing is investigated by Rubel and colleagues in this study. They interviewed 27 women and 12 partners who had a variant of unknown significance reported during pregnancy and was faced with the decision to continue or terminate pregnancy. These parents struggled to quantify and interpret risk for the specific phenotypes associated with their genetic result. As one of them said, when you look online, it's just nonsense. They experienced a gap between what was known and what was needed to make a decision. And the authors show how uncertainty prompts other ways of knowing, such as the embodied gut feeling expressed by Simone, or a spiritual understanding that the child had chosen the parents for a reason. The authors argue that we need to acknowledge and support other ways of knowing, and ways of bringing other ways of knowing and bring these values into the clinical discussion. Because once Simone has arrived at the realization that she wants this little copy of Daniel, she doesn't need more information on risks and statistics. So Daniel and Simone continue pregnancy with their baby boy, and Simone generally manages to push the genetic result to the back of her mind. However, since there is a small risk of heart malformations, she goes to regular ultrasound scans, which is taking a toll on her. She hardly sleeps the night before because she's so nervous. Daniel is happy about the pregnancy, but feels a little responsible for having passed on defective genes to his unborn son. He wonders if he will feel guilty about his son's future struggles. Luckily, almost a year after his birth, little Luke is meeting all his milestones and is developing normally. Simone tells me that they hardly ever think about the 22q11 result. I think about the genes in the sense that I focus on the language and his motor skills. But I don't really think that I would have acted any differently with another child, because it is in my interest to promote his development through support and motivation. It's hard to talk this much. It's in my interest to promote his development through support and motivation. However, in my talk with her, it was also very obvious that the genetic result was something that could take forefront again, should Luke's development stall. Simone saw the knowledge about his genes as an opportunity to be proactive regarding Luke's development. This tendency to use genetic information to interpret the child's behavior has been investigated by several scholars, including in this other paper by Lynn and colleagues. They interviewed 23 mothers of infants diagnosed prenatally with a potentially pathogenic copper number variant. And though most respondents reported their children to develop normally, the majority also expressed concern about future development. 6 mothers described a state of intense, active, and worried monitoring over their child's development. One mother said, "I'm constantly questioning, is this because of her disorder? For example, she's a really bad sleeper. So for the longest time I thought, wow, is this her deletion, or is it just that she's 5 months old and she sucks at sleeping like most babies?" The authors argue that these children risk becoming patients in waiting, where the genetic information becomes the primary context for understanding and monitoring the child's development. Parents are, so to speak, waiting for the CNV to happen, taking precautions and being ready to intervene at first symptom. It's what Bernard and colleagues have called toxic knowledge. The potential difficulties and frustrations of having uncertain genetic information about your child was also investigated by Desai et al. In this interesting paper, I hope I pronounced the name correctly, otherwise I apologize. They found that parents who had received a prenatal genetic result were invited to fill out a questionnaire at 12 months and at 36 months after birth. The questionnaire assessed perceptions of children's development, parent-child attachment, attitude to genetic testing, and so on. They then compared responses of parents who had received a variant of uncertain significant result, a VUS result, with parents with normal or likely benign results. Interestingly, this comparison showed no significant differences, except that parents in the VUS group rated infant competency lower at 12 months compared to parents who had received a normal result. However, that difference had disappeared at 36 months. Interestingly, at 36 months, the parents in the VUS group expressed significantly less satisfaction with the decision to test compared to parents with a normal result. The authors suggest that at 36 months, parents viewed their child as developing normally, and they regretted having gone through a period of unnecessary worry. The authors suggest that more guidance should be provided to assist parents in coping with ambiguous results, and I hope that my presentation has provided you with some inspiration for how we can best support expectant parents like Daniel and Simone. So where are they today? Well, little Luke is still meeting his milestones, and thoughts of a new pregnancy are slowly emerging. However, this also leads to new uncertainties. I'm not completely sure if I want to be pregnant again because mentally it was just a really tough pregnancy due to all this. So I'm not sure if I want to go through it again. At least you kind of have to prepare yourself for that situation. So the uncertain pregnancy with Luke actually makes Simone hesitant about the pregnancy. She is, however, very clear on the genetic testing. She definitely wants it. Just to know, of course, she would never terminate a pregnancy just because of a 22q11 duplication. Daniel is less sure. He feels the pressure of being the one with the defective genes, and he definitely wants to look into the possibility of pre-implantation genetic testing. In our final interview, Simone was very surprised by his feelings about this, and they almost had a bit of a quarrel. So I wish all the best to the geneticist who has to help them figure that one out. As we leave Daniel and Simone, I want to finish this presentation by concluding that an uncertain genetic result does create uncertainty in parents, but we can support them by sharing uncertainty, by emphasizing what is known, and by suggesting management strategies. Prenatal genetics is difficult, that's why we love it. And I think it's so important that we continue to listen to and learn from patients, and that we continue to honestly discuss our own values, concerns, and uncertainties. Now, I hope to see you for the discussion on Monday evening, or that you will send me an email if you have any comments or questions, or if you want the reference list. The topic is so important, let's talk about it. Thank you for your time and for making it all the way through this presentation. Take care.